Okay, so good evening, everybody, and welcome to this webinar that will discuss guided bone regeneration and the evolution of these techniques and to see how biology can meet function but also aesthetic in the treatment of the bone deficiencies. Well, we have to think that guided bone regeneration is a quite young discipline because it was introduced only in the 90s. Before then, the only university or school that was taking care of this kind of problem was the School of Loma Linda with Professor Boyne, because American people were at war. So there were a lot of soldiers coming back from Korea and from Vietnam with a lot of facial problems because of wound, of gunshots, bombs, shrapnel, all kind of problems. And actually, they were the first one to try to think of solutions to restore osseous defects in the maxillofacial district. Nowadays, we can often run into problems like this, and you can see in the CBCT, this patient was a gardener just pruning some trees with a chainsaw, and they tripped on his ladder and he cut his face, his teeth, part of his nose. And if you look at the CBCT in the occlusal aspect, you can see the damage that was done not only to the teeth, but to the soft tissue and to the bone. So without a technique that is capable of rebuilding the bone first, and we see also how the bone and the soft tissue basically work together, patients like this would actually have a very difficult time. So let's look at the biology. Biology is very simple because whenever we want to have a bone formation, we have seen the other day, I don't know how many of you were attending the webinar on guided tissue regeneration. Whenever we need to do regeneration, we need certain conditions that are the basic condition. So basically in biology, bone formation depends on two basic concepts: blood supply and mechanical support. So there is no possibility to have a bone graft working without some blood and without some mechanical support. So the bone graft should be very, very stable, like I showed the other night whenever we do the grafting around the teeth. Because the osteoblasts work only in the immediate neighborhood of blood vessels. So if we want to have healing like this, we need to have blood supply and mechanical support. Actually, the activation of bone regeneration is quite simple because about 30 years ago, when I was a student in Boston, in our implantology course, we had a very important guest lecturer. At the time, that was Richard Lazar. You probably know Richard is one of the master in implantology. He was the one who invented implant innovation in the United States, nowadays called Biomet company. And was the first one to introduce the use of immediate implants into extraction sockets because he discovered that whenever we extract a tooth, if basically we do nothing and we come back after 5 or 6 months, if the tooth was broken, there was no periodontal disease, so in a normal condition, when we extract a tooth, after a number of months, we go back in the site and we find bone. So any bone lesion that can be a fracture or interruption of blood supply or extraction activates the mechanism of bone regeneration because the periodontal ligament cells release growth factors. And the bone is a tissue that is very rich in growth factors. So the insulin growth factor, the transforming growth factor beta, fibroblast growth factor, and platelet-derived growth factor are all synthesized in the bone-related tissue. So you know that whenever you have a traumatism, if you make the bone bleed, you will get these cells that are the one helping the bone to regenerate and to heal. And of course, the osteogenin and the bone morphogenetic proteins that are the bone-inducing factors in the bone marrow are very, very important. But let's get to business, because tonight it's a very, very clinical presentation. You will see a lot of cases, a lot of situations, and how to handle different kind of problems. So tonight we're going to see 3 different paths. We will see what happens when we extract one tooth. We will see what happens when we extract multiple teeth. We will see what to do when we have wide defects. So I think we will start dealing with single tooth extraction. Well, the most important key is that we are the one, often the times, or more often than what we think, to create a problem because we do traumatic extraction. So if we start thinking that every time we extract a tooth we have to be very gentle, well, the human body will give us a reward in terms of regeneration, and what we will have to do afterward will be less, and less is more, as we know. Okay, this is a very popular study that everybody probably knows, the study of Araujo and Linde, showing that every time we extract one tooth, or more than one tooth, as you can see, the buccal plate, that is the one on the left, indicated with BB, is very, very thin. So what happens after the tooth is gone? The bone resorbs inward and backward. So we have a kind of a centripede kind of resorption. Therefore, the problem is not only that we have less bone, but even the position and the condition of the soft tissue becomes very different. So this is a very important study. It's quite dated because it's a study of 2003, but Karing and his group did a 12-month prospective study. They extracted teeth, and they evaluated radiographically and in the stone cast what were the morphological changes after 12 months. And I have to say that the results were quite shocking, because their conclusion was that the most changes happened within the first year, of course, after extraction, and the reduction in volume can reach up to 50% of the original bone volume. So imagine, by doing a tooth extraction, you may end up having 50% less of the original bone volume. So quite significant. Well, let's start talking about single tooth extraction, and especially when we deal with the tooth in the aesthetic zone or in the anterior area of the mouth, we have to be very, very careful, because the teeth have very thin buccal plate, and anatomically they're placed in a position that can be quite challenging to fix. Well, Angela, at the time of the first consultation, was 42 years old. She had a traumatism on a front tooth, and she was asking for a solution. You can see on the right side of the screen that Angela has a very broad gummy smile. So whenever she smiles, she shows pretty much what's the situation. Therefore, we have to be quite careful and plan this case very carefully, because if we do something wrong, I mean, it will be a very bad advertisement for our work. So basically, studying the case, you can see that the tooth had been treated with an apicoectomy in the past. You can see that in the intraoral radiograph, you can see it in the CBCT. But in the slices of the CBCT, you can see that the buccal plate is basically gone. So you can imagine that once you extract a tooth like this, you have to deal with a severe kind of defect, because if you want to replace the same anatomical situation, you definitely need to do some kind of grafting. So basically, it's quite important to be delicate to the soft tissue. You can see very well here that the incisions were intrasulcular, the papilla in the central incisor was split but left in a way that we can rejoin to these two bed joints after the sutures, and we try to minimize the traumatism. Well, even the extraction, if it was traumatic, you would not have seen like a cone. You can see that the shape of the tooth and it's like a cone going into the bone. And we have two bridges of bone mesial and distal to the ridge, so that this is a good anatomical, it's a favorable anatomical situation. So what we did was to debride completely the defect from the granulation tissue to do some intramarrow penetration with some burrs. And then we grafted with MP3. MP3 is a porcine collagenated bone graft. And we covered it with a resorbable membrane called evolution membrane that is hydrated also with the blood clot of the patient. We can use the membrane in multiple layers, so you can see the first layer, and then you can see that there are a couple of layers. And you can also leave this membrane exposed. So this is an advantage of a resorbable membrane. We saw the other day the non-resorbable membrane that are not anymore available. I mean, the one for GBR are actually still available, but the one for periodontal reasons, they're not available anymore. And of course, if we leave one of these non-resorbable membrane exposed, we create a problem beforehand. So by doing this with a resorbable membrane, the soft tissue will granulate and we will get a nice healing, as you can see here. And a few weeks after, the situation looks okay. So we're very lucky because Angela lives going around Italy, and she comes to the office 1 or 2 times a year. So giving her a lot of time for recovery, it's a good thing, because when she returned about 12 months after we did the surgery, you can see that the shape and the contour of the ridge simulates pretty much what was the situation when the tooth was there. So let's look at the soft tissue now also. This is the hard tissue. Well, this is a publication that we did in 2017 with my friend Eugenio Longo and with Eitan Mijiritsky. Eitan is the chairman of prosthodontics in the University of Tel Aviv, and he's one of the most famous and qualified prosthodontists and guided implants specialist. This is why we published the paper in 2010, so 7 years ago, and 9 years ago. And in 2017, we replicated the concept that whenever we build everything nice, so if we are able to do a nice GBR and to have the soft tissue in place, you can see here that the tooth is in position. You can see that the papilla to the mesial and to the distal is there. The volume in the mesiodistal space is there. So why to go back and do a conventional surgery? So why to go back and open a flap? Completely unnecessary. So we do the study with the software, with the stent to do guided implant surgery. And now let's watch the video on how this guided implant procedure is performed. There is an initial burr. The initial burr is the one drilling through the stent and giving us the direction of our implant. And it works like basically a 3-fine, and it removes a little core of the connective tissue and the epithelium. And basically, you can see that once you have opened your small flap, you can put the temporary crown in place, and the temporary crown will actually start conditioning the soft tissue from the moment zero. So it's a fantastic way to do soft tissue conditioning from moment zero. So the first burr is the one that give us now the direction, and then there is a series of keys. These keys are the one that lead the drills into the bone with a lot of irrigation. You can see we do a gentle movement up and down. We go from the 2 millimeter to the 3 millimeter diameter to the 4 millimeter. In this case, we plan to place a 5 millimeter diameter implant, and you can see that we put the proper key, the burr, and then we drill. The movement is very gentle, up and down, without a lot of pressure. There is no bleeding. See, it's a very atraumatic kind of procedure. So now we're down to 3.8 diameter. Now we go from 3.8 to 4.3, and we are pretty close to the final drilling for the preparation of the site. So now we are ready to place the implant. The implant has a driver. The driver goes through the stent, and you can see that the pink driver has a lot of scratches because very often we find quite a resiliency from the bone. So the drill, we start at 30 Newton centimeter, then we increase the torque to 40 and then to 50. And then if there is such a good stability, we keep going with a hand wrench. And then we measure the ISQ of these implants. If the ISQ is above 60 or 70, we can think of doing immediate loading. So we have the temporary crown there ready. We have the temporary abutment also there ready. So my office partner, Dr. Alessandro Conti, is ready and is doing his procedure. So he connects the crown, the temporary crown, to the implant, and we start doing the conditioning of the soft tissue from day zero. This is about only 1 week or 10 days after the procedure was performed. So basically this was the study of this case, the way we planned the stent and the procedure. And this is the implant in place, where you can see that when the interproximal spaces to the right and the left are so narrow, you can bet that you will have a good soft tissue and a good papilla. This is about 8-9 months after. We just do a simple evaluation of the parabola of these crowns. We have to do small adjustment in soft tissue conditioning, but when we remove the temporary crown, you can see how nice, how beautiful, how healthy, how thick, how stable are the soft tissue around this implant. So this is the final restoration in place, and when actually Angela smiles, now she has a nice biomimetic invisible restoration, and since she has a broad smile, it's quite good that we were able to hide the problem and actually improve the situation. It is very important to assess stability. So I want you to see that in 2010 we had this kind of situation, and in 2018 we did a new CBCT of just control, because we want to make sure that what we do is stable. And you can see very well that, remember, we had no buccal plate. Now we have 2 to 3 millimeters of fully reconstructed and mineralized cortical buccal plate. So when we do these kind of procedures, we want to fix the problem and make sure that the problem stays as it is for a long period of time. So you can see here that Angela is aged a little bit, because of course has been actually 8 years. So 8 years is a long time, and of course when we go through these kind of things, it takes a lot of time for proper healing. One important concept is that nobody ever talks about when we do this grafting procedure, how much we have to pack the bone graft into the extraction sockets or in the areas where we want to do regeneration. Well, there was this interesting research done by a Chinese group in 2017 that compared different compression forces and assessed that 30 Newton is the best force that we have to apply to the bone graft in order to get a stable and maintainable ridge preservation. Well, let's look now at another case. Another case where we can really see that this patient is coming, a young lady coming from Cuba with a very poor restoration. You can see the shape, you can see the color, you can see the damage and the endodontic lesion that is in the bone. And of course, being very young, she wishes to have a better situation. Ines, she's going to marry an Italian, and coming from Cuba, she would like to have a better smile and to smile in a better way. So basically, we assess the situation, we do the CBCT, and in this case, you can see that the kind of biotype is slightly thinner than the one that we had before with Angela. So it will be a different situation, but quite similar approach. So basically, we have to open the flap, and in this case, you can see that we don't have as much vicinity between the two edges of the residual bone. So basically, this defect is a more complex defect than the one we had before. Nevertheless, we do just exactly the same procedure. We take our bone graft, we hydrate the bone graft with the blood clot of the patient, and then we cover the whole complex with a resorbable membrane in multiple layers. So you can see in the picture to the left that the membrane is left exposed, but within a week you can see that the membrane is not there anymore and the soft tissue is already granulated on top of the membrane and is actually growing back, covering the defect that we had there. So the non-resorbable membrane is quite important. Let's look now at the way this procedure is carried out. So it's quite important that the extraction is very, very gentle. It's vertical and is done without putting any kind of push or any kind of pressure. The socket curettage is quite important because we want to make sure that we get rid of all the granulation tissue, so there should be no residual granulation tissue at all in this situation. And basically, we use this long shank burrs that are called the perioset burrs from intensive, and we try to debride as much as possible this extraction socket. So the necessity of the flap is because even after I have opened my flap and I've done my very thorough debridement, I will still find some granulation tissue down there. So imagine if I had just trusted my closed curettage, I would have failed because the quantity of granulation tissue is still there, there's plenty, and actually I need to really go deeply and debride this defect all the way to the end. So basically now we are ready for the bone graft, and the bone graft is actually packed in the area, and you can see that the bone graft is actually activated with the blood clot of the patient, and then pushed into position with a periosteal elevator, and then packed with some sterile gauze, making sure that there is this 3 kilograms of compression so that we know that the bone graft is not going to just fly away for any reason. Then, of course, while we're doing this, we prepare the evolution membrane, and the evolution membrane, you can see it's basically dry, and once we place it into position, it becomes hydrated again with the blood of the patient. And in this case, since we want to give a good protection, we can do a double or actually even a triple layer. So we hydrate the resorbable membrane, and with the tweezers we just put it in the position that we find more convenient before we are going to close the flap and actually suture back the soft tissue in the position that should be the best. See, we help each other with a tunneling knife. The tunneling knife it's very, very useful in this situation, and with the resorbable stitches we set up the case, and then we just bond a Maryland bridge for the patient to go home and to see the bulk we created. You can see the graft is fully in the area of the extraction socket, and about 1 year down the line, when we go back to recheck the situation, you can see that we have a healing, we have reconstructed the bone, and there is actually an over contour, so the bone is actually in excess. This excess of bone will be actually meaning that we have a lot of soft tissue and a good quality of soft tissue. So you can see how the radiographic image reflects into the clinical aspect of the area. So now we are used to do the digital smile design, so we can use that principle in this situation. So we basically take the shape of the neighboring tooth, we reflect it sideways, and we can see that actually we are very lucky because this healing of the bone underneath has led to a healing of the soft tissue as well. So we have both bone and soft tissue actually in excess. So we are very lucky. We are very lucky, so the moment we place the implant and the temporary crown, we get a little bit of inflammation because the patient is not going to brush for the first week, but a very nice immediate result. So again, we study the case with a guided implant navigation system. We perform a guided implant surgery and we place the temporary crown at the time of the procedure. 1 week post-op, again, you can see that everything looks nice. Luckily, Ines has a smile line that is a little bit shorter than the one of Angela. Therefore, we are very lucky because she does not really show much of the problem. But look at about 6-7 months after the temporary has been in place, how beautifully is the shape of the soft tissue, stability of the papillas. It's very important to be very patient when we do aesthetic cases like this. We want to do it slowly. If we do it slowly, we let the bone mature, we let the soft tissue mature, and the whole complex will remain stable in the long run. In this case, we were actually playing around, so we did 2 crowns. We did one analogic and the other one with the digital system. We delivered it to Ines, and Ines, as you can see, was very, very happy because she could finally smile without any concern because of her young age. She had a beautiful restoration going from a very compromised situation to a much more natural one, and of course aesthetic as well. Well, let's look at the importance of alveolar ridge preservation. There are many studies. This one was done in 2017 and showed that ridge preservation, especially in the anterior area, is very important when we want to achieve an aesthetic result. I want to show you a very, very old case because this is a patient I treated back in 1999. So exactly 20 years ago. It was a case that you can see had a very large internal resorption. So I had a chance to think of what was the treatment plan. And the treatment plan, upon looking at the CBCT, was to extract the tooth and do ridge preservation. Ridge preservation in 1999 was not a common procedure to do. It became a common procedure only later on. But I think at that time I was using growth factors already, PRP, and I decided to extract the tooth, put a bone graft that was hydrated with PRP, and I wanted to have a healing like the one that you see in the center. So the soft tissue and the hard tissue basically are in place. Then we did not have any implant navigation system back in 1999 because they came out in the market only after 2000. But we had the idea of doing what now we do with the guided navigation system. So we did a model-based study just by doing a stent and measuring the thickness of the soft tissue all around. And then we did the implant with a flapless approach. I presented this case in the convention of 3i Biomet, and Richard Lazzara was actually attending the convention, and he became quite aware of the fact that we introduced a concept. As you can see, we placed an implant that was 5 millimeter wide, and then we restored it with an abutment that was smaller. The rationale for using a smaller abutment was that we wanted to be able to put a lot of acrylic on the restoration, the temporary crown, so that we could get a good soft tissue conditioning. Richard Lazzara became quite interested with this idea, and 2 years after, in 2002, in the International Congress of the European Academy of Aesthetic Dentistry in Venice, he introduced the concept of switching platform based on this case that you have seen. So this was the case that gave the world the idea of using a switching platform when we do implants for conditioning the soft tissue. So basically, after about 3-4 months that the patient was carrying the temporary crown, we did the final restoration. We cemented all CERAP crown that, as you can see, looks nice. The soft tissue looked just as good, and the biomimesis of the root and crown that is the same length and shape of the neighboring teeth is quite important. But there is a story of this case. In 2000, so about few years after, everything looks okay, but the patient returns for follow-up. You can see that the healing and the soft tissue are very nice and very stable, but someone will notice that something is going on. Well, the patient decided to have orthodontics because you can see she had the teeth in the bottom arch that were crooked. And the orthodontist did not do a good job thinking that she had an implant in her mouth. So what happened years after? This was the situation and the follow-up that was perfect, but what happened? Well, you can see she aged. She was only 17 when she came for the first consultation. Now is about 17 years after. She aged and she has to get married. And she said, I cannot get married like that because, see, my tooth looks shorter. So we tried to establish the situation, and what happened? Well, because of the orthodontic treatment that was performed not in a nice way, there was a passive eruption. So the teeth, the neighboring teeth, erupted. Of course, the implant is just like a post placed in the wall and cannot erupt. So, of course, the implant now looks shorter, although the soft tissue all around looks beautiful, the tooth looks much shorter. So, after 20 years, look at that. The stability of the soft and hard tissue is there, but we had to redo the crown, making it a little bit longer because she had to get married and she wanted to smile well in the picture of the wedding. So this is quite important to know that we have to be careful when we do orthodontics in patients with implants because this may change what is around the implants. If we have a single tooth replacement, that can be affected by our procedure. Well, this is another very interesting situation. This is instead a patient that had orthodontic treatment, but the orthodontist lost sight of the fact that she had a central incisor that had a root canal therapy. So probably the movement of this tooth distal, instead of creating resorption in the bone and apposition in the other side, created a tooth resorption on the tooth. So we're studying the case. We are very lucky because Daniela is actually has a low lip line. So it will be just because of our pride that we're trying to do a good job in the soft tissue side, because when she smiles, she actually not showing anything. But I decided to become a little bit creative in doing my surgical procedure. And I extracted, as you can see, very, very gently the tooth. It was extracted so gently that it was basically intact, although there was a large resorption. Most of the tooth structure was in place. So what we did was to just cut out the root and just fix the crown aspect with some nice composite restoration. Place the implant in the more palatal aspect, graft some genos well packed into the whatever was left of the buccal plate, and we replaced the natural tooth to just become the temporary crown. So imagine, you can see on the upper picture that the tooth was slightly extruded, And after the implant was in place, the tooth was placed in the proper position, so it could actually support and maintain the soft tissue in place. Well, it was very nice because after 1 week, when she came back, it looked like she did not have the tooth extracted. So nobody can tell that the root is not there and there is a titanium root now. And at 6 months, when we removed the natural tooth from the place, we had already a beautiful, beautiful, fantastic, stable complex of the bone to soft tissue interface in order to place a final restoration. We delivered a lithium disilicate crown, and of course, 1 year down the line, you see the perfect stability of the soft tissue. You see the shape, and you see the color and the texture of the soft tissue around the implant look actually better than the one around the teeth, where she brushes a little bit too hard on her left side. But again, the key of it is to maintain these situations in the long run. And if we can really plan and do this carefully, we can get good rewards, because after 8 years, everything is nice, beautiful, and basically also stable. So this is a completely different situation. Here we are dealing with a single tooth extraction, luckily not in the aesthetic zone, but unluckily in a very unfavorable situation, because first of all, you can see the crown is gigantic, so it's really way, way bigger than what a molar should be in this area. Secondarily, you can see that the amount of bone loss because of the probably endodontic or the complication of endodontic and periodontal problem evolved into a massive bone loss. So you can see that in the CBCT on the left side, the red dots highlight my idea. I really have to think out of the box in this case. I have to just become creative and find a solution, because she's a beautiful lady. She is a friend of my wife, and she is also a lawyer from New York, so it's somebody that it's a dangerous patient if I will not do things carefully. So you can see that after extraction, the defect is really huge. Is actually vertical and horizontal defect. There are two components to the defect, so the worst enemy of people that are trying to regenerate in a situation like this. So the idea was to debride completely this defect and really score to bone to find the scratch and make sure that we get really all the granulation tissue away. Then we packed the bone graft. In this case, we use MP3. MP3 is a collagenated porcine bone that has a little bit bigger size of particles that is probably one of the gold standard in the sinus surgery when you do open sinus elevation. And then I decided that I could not use just a resorbable membrane, because to hold on to a big of graft like this, I needed something a little bit thicker. So we have a biomaterial that is called derma. Derma is basically connective tissue. It's a xenograft. Is a porcine connective tissue graft that is quite interesting. Has been used in mucogingival procedures. We have a number of studies done in Germany by Kai Fischer, Stefan Fickel, and the German group is doing a lot of studies on it. In Italy, we just finished to do a study with the University of Geneva with Antonio Barone and Gabriella Grusovin that is in publication now. But this resorbable, basically connective tissue graft is fantastic because it's rigid, it's thick, and it will work like a non-resorbable rigid membrane. So I place it, I put my crisscross sutures, and then I wait for the healing. So you can see before extraction, when I debrided the defect, and to the right side at 4 weeks, something is already brewing in the area. You can see that the soft tissue granulated on top of the derma, thickened, so we now have the thickness in the soft and also in the hard tissue. The problem will be to find the proper size of implant, because here, to support a large molar like this would be a challenge to have a standard diameter implant, because this is quite a voluminous situation. Well, let's look at the healing period. Things are getting better. We can see that now we're starting to see after 3, 4, 5 months some vertical augmentation, but we still wait. And actually 1 year down the line, when we reevaluate the case, we can see that we really have what we had in plan. It's actually become reality. So we have the shape, we have the size to put our implant. So this is the story of the case, before extraction, with extraction, with the graft in place. And now we're trying to find the proper size of implant to support this crown. Well, there's a very interesting study done by, again, my friend Eitan Mijiritsky, along with Serdar Yalchin, that is the chairman of implantology in the University of Istanbul, that shows that the effect of crown to implant ratio and implant dimension is quite important, because the peri-implant supported crown will have less stress if we have a large implant in a situation like this. Luckily, we had a nice implant with diameter of 8 millimeters that we placed with a flapless technique, so very minimal invasive. And you can see that this wide diameter implant really keeps the space of the roots that are missing quite well. So this is after the implant has already reached osseointegration, the trying, the fitting of the crown, and then the final restoration that perfectly fits in this situation. So this was the day of delivery, and I think about 5 or 6 years down the line, in a follow-up, you can see how biomimetically the crown looks very nice, and the soft tissue look as well very nice in a situation that was almost an impossible case to treat. But let's look at one more case of single tooth, and then we will pass to other solutions. This was a case that had not only a periodontal problem, but also increased mobility. You can see that there is a 7 millimeter pocket on the mesial, and there is a 9 millimeter pocket on the distal, plus a furcation involvement, so it's a tooth that cannot stay in the mouth. Even in this case, the extraction will have to be very, very careful, very, very gentle. So what do? We section the tooth horizontally, and then we extract the mesial root coming distal and the distal root coming mesial, so that we don't damage whatever is left of the extraction socket. With the bride, completely, we place the bone graft, we put the resorbable membrane. You can see in the radiograph, after the graft, you can see that there is a lot of stuff going on in this socket. But within 5 or 6 months, in the mandible, we don't have to wait long. 6 months, 4 months, you have already quite a mineralized situation. When we open the flap, you can measure the millimeters. We have about 8 or 9 millimeters boccolingually. So in this case, we placed a 5 millimeter implant, and you can see how much of the bone we have both in the buccal and the lingual. So we were able to reconstruct the bone ridge to ridge in a severe case of bone loss in this case. So you can see to the right the regeneration that is completely flat, and on the left side how the situation was at the beginning. So this is the story of the case before the graft, after the graft, and with the healing, with the implants in place, and with the final restoration. So this is an interesting case because we have a long follow-up on this. It was part of a study that we did and published between 2010 and 2014, and we published it in 2015. We were studying implants treated with and without platform switching. So we were trying to evaluate if there were radiographical changes, so if there was more stability in the sites treated with switching platform or the one with conventional platform. And we did not find really any difference in this study. So we were very lucky to show that switch inflatable may have an effect on the soft tissue, but on the bone level, in this case, there was no difference. So look at this, at day 0, so when we delivered this final restoration, you can see that we did not have any papilla. In the medial and the distal, you have 2 black triangles. So it's a situation that looks quite odd. But let's review this case. This was day 0. Look at that. You look at the position of the bone crest, medial and distal, and you look at the distance between the bone crest and the interproximal contact point. If this distance is within 5 millimeters, the papillas are just going to come back. Well, this is the same patient, and this is a long follow-up. 11 years. 11 years after, you can see that everything is nice, stable, and we actually have our papillas back in the medial and in the distal. So the stability of the situation is very much run by what we do. But remember, I'm Italian, so I have to follow the lead of the greatest architect, physician, and historian. Leonardo da Vinci gave us a very important hint, that simplicity is the ultimate sophistication. So when we do things, the more we are simple, the more we are sophisticated. Therefore, sometimes when we have narrow ridges and we have difficulties in deciding what kind of graft to do, we should not do any graft. We should just put small implants. In this specific case, we studied the case with a guided navigation system with Nobel clinician in this case, and we could assess that all the implants that we were going to place were going to have dehiscences. Those yellow marks that you can see in the bone are just dehiscences. So why would I take a chance to put implants that will have a dehiscence? So this is an old lady, I have to play it safe. So we elected to put narrow diameter implants. We did the guided, partially guided. It's a modified guided technique, so guided but with an open flap. And eventually we reached a nice result because we were able to give a fixed restoration to the lady. She can enjoy, she can smile, she can function well. So we don't really have to graft at all costs, because if we want to graft at all costs, that sometimes can be a little bit costly. Well, talking about, going back to talk about ridge preservation, the Cardaropoli brothers in 2008 did a nice study, and they demonstrated that it was possible to preserve 85% of the original ridge volume whenever we were using a bone graft. So why not to do it? Let's look at the literature and what the 2 people that have studied the most the ridge preservation techniques, that are Linde and Maurizio Araujo, have to say. They did a number of studies. They did it with basically autogenous bone. They did it with beta-tricalcium phosphate. They did it with xenograft, and they did it with BIOS collagen. All of them work. So it's really, we will see, up to you, clinician, to decide what you find more convenient and better for you. Well, for sure, now we have a news, a very interesting concept. Actually, there was a study that was published a few days ago by New York University. Some good friend of mine, Ziv Mazor and Robert Horowitz, did a nice publication about the use of the smart dentin grinder. Whenever you have a periodontally involved patient, so you have basically bone loss, but you have teeth that are perfectly healthy, because when you have advanced periodontal disease, the bone is lost, but the teeth are perfectly healthy. You can just clean them very, very well, debride them, and just grind them and use them as a graft, especially when we have big cases to do. Let's watch a video, the way the Cometa Bio dentin grinder works. In this case, we had to extract this central incisor, what was severely compromised with the periodontal disease. So we take the tooth. This is the kit that comes with the grinder. So we get one chamber, we get the buffering solution and the sterilizing solution. You put the tooth in the grinder and you see the first cycle is 3 seconds. And then you see there is a new movement, and you can see there is a separation between the enamel that remains into the grinder and the dentin that is collected into the chamber underneath. Now you have two different chambers, so you can have two fine and finer particles of dentin. So it will be up to you to decide which one are more effective for the use of the graft that you have to do. So cleansing solution for 10 minutes, and then disinfecting it for 3 minutes. So 13 minutes plus 2 of grinding, 15 minutes in all, and you get basically your graft ready. And then you mix it with the autogenous blood clot. The patient has already clotted quite well after you have extracted the tooth. You can see that you place your bone graft in the area with your periosteal levator in this case, and then you push it. Remember the 3 kilogram of force. We use sterile gauze to help us to just push the bone graft in place, and that's it. You pack it very, very well, and this is the best autograft that you can do because you put the dentin back where it belongs. So this is after, this is the buccal view, and then you will see about 2 or 3 days after the grafting that the healing is always incredible because it really, the body responds very, very well. Few days after, this is 3 days after the graft, and everything looks already very, very nice. So now let's look at the case that needs exactly what I said. See, we have to extract all these teeth because they are hypermobile. So we have to replace them, and we have to replace them with dental implants. So what do we do? Well, basically we will watch it in the video. We will do a full arch restoration, and we extract very carefully the teeth. We clean them. We remove, of course, the crowns. If there are root canal therapy, we just have to open the tooth, remove the gutta percha, clean up the area, and put just the dentin into the place. We do the planning. The planning is done with the digital dentistry. See, we do the study. We check what's the best color for this old lady. We take the face bow, and then we design this case in the CAD/CAM, and we perform the multiple extraction, but we have also a stent to perform guided implant surgery. So we mix different situations, and in this case, even if we have to do multiple extraction, you will see how we will end up grafting the denting of the extracted teeth into the area, and how can we get to a nice point in terms of healing. So the teeth has to be very, very clean. Again, 3 seconds of grinding, and then 15 seconds of shaking, and then we get nice particles into different shapes. Again, we do first the disinfection and then the sterilization, and then we are ready to place our implants. So with the stent that we used to actually assess the case, we know what are exactly the position of the implants. We do everything flapless, and now it's time to graft the sockets. See, the implants are already in place, and we're going to graft the edentulous sites and wherever is necessary near or around our implants. So now we are ready to take the impression. We put the healing abutments, and within 24 hours the dental technician prepares the temporary crowns in PMMA, and 48 hours later look at that the soft tissue have already healed, especially the sites where we did the dentin graft, and look at that, you don't see any kind of bone loss because we basically put everything back. We can give a decent aesthetic to this lady. We will see. This was before. This is just 2 days after we have done the procedure, and the case is doing very well. She's very happy. She started like that. Now she is, as you see on the right side. And this is a recent Panorex 4 years after. You can see the stability of the soft and hard tissue, and now the patient enjoys a better oral hygiene and a maintainable situation. So it's quite interesting to see how these patients can really react to our procedure. But now let's look at a question that we may arise from what we have seen so far. When do we decide to do immediate implants, and when we decide to do socket grafting, ridge preservation, and of course, a two-step technique? Well, this is another interesting study done by Araújo and Linde in São Paulo in Brazil. They evaluated the CBCT of 250 subjects, 17 to 66 years old, all with the teeth. They did CT scan, and then they evaluated the thickness of the bone, 1 millimeter, 3 millimeter, and 5 millimeters below the bone crest. Well, the very surprising result was that often the facial bone was less than 1 millimeter thick, and 50% of the sites evaluated had the facial bone that was less than 0.5 millimeter thick. So, situation where if we would do an immediate implant would be quite risky. So now we can say that today with digital technologies, with digital dentistry, and with CBCTs and 3Ds, we have a big help because we can really evaluate in advance the anatomy and see what things are going to happen beforehand. So if we have to think about ridge preservation versus immediate implant, let's see what are the way we should think. Well, first of all, we should consider the anatomy of the defect. So if we have enough walls, especially if we have the buccal wall. If we have the buccal wall, it is likely that we can do an immediate implant. If we have availability of bone apical to the socket where we can find the apical threads of the implants gaining stability, enough stability, and if we own a device that can measure the ISQ, well, we can do that. If the angle of the defect is favorable, because if we have a certain angle, we can see that the sharper the angle, the better the prognosis, just like we saw 2 days ago when we were talking about the teeth. Of course, the size and the length of the root and the implant, because if the root is too big and the implant is not achieving good stability, forget about doing an immediate implant. And of course, the local anatomy, because if we have the limitation in the upper jaw from the sinus and in the lower jaw because of the mandibular canal, we have to be very, very careful with that. Well, when we have large defects, this is a case that, as you can see, had a huge cyst. The cyst was mesiodistal, buccolingual. It was the shape of 1.5 centimeter vertically, 1.5 centimeter mesiodistally, so we had only one choice. It looked like the head of the octopus. We extract the tooth, we graft with MP3, we wait 6, 7, 8 months, 12 months. When we see the bone graft that looks like the surrounding bone, we know that we are ready. So in this case, we did the surgery with the guided implants, the R2 gate of Megagen. We placed the implant, and you can see the beautiful result in terms of maturation of the bone graft, maturation of the soft tissue, and biomimetic of the crown. It's very important, but this will be the topic of a webinar that I will do in the end of September. So those that are interested in understanding how this implant navigation system work, how we can use them nowadays combined with the CAD/CAM technology and simplify our life, the one of the patient, become predictable and enable us to do immediate implants, we will see it in the end of September. When we have large defect, but we have a good anatomy, we can do the combination of the two procedures. So we can place the implant and the bone graft exactly at the same time. Now let's move forward and let's say that the implant navigation system really have changed our life because they gave us a lot of information. They gave us a lot of hints on how to behave and how to treat this kind of patients. And I was author of a nice publication that we did in 2010 with a group of friends that basically was addressing the use of guided implant surgery in cases after GBR. And exactly, this is the study that comes before the one of 2017 that we published with Eitan and Eugenio Longo. And basically became a classical study because nobody before was thinking of using guided implant surgery in aesthetic cases. So this was the case. We had a nice young lady with a beautiful smile, but with a tooth that was failing because I had two apicoectomy in the past. And as you know, apicoectomy is a subject that leads quite often to failure. And in this case, you can see that the tooth became infected, and we had to extract it very, very carefully. Again, remember the study of Schropp and Karing of 2003, that if we don't perform ridge preservation, we may lose 50% of the bone while we're doing the procedure. I just switch on the light because probably in your country it is night, but here in Italy it was still daylight, but now it's becoming dark. And of course, what we plan to do in this case was to gently extract the tooth. To pack a bone graft, we used a Genos hydrated with the blood clot of the patient. We packed it very, very carefully. We did not know yet how much pressure we had to apply to the graft because it was more than 10 years ago. But the idea was the one to try to maintain the buccal bulk, to push the soft tissue buccally. And actually 6 months after the procedure, when we returned to see the patient, you can see that things looked quite okay, especially in terms of papillas. We had the mesial papilla and the distal papilla, so the situation was quite reasonable. Well, the point is that we should never look at the problems only from one aspect. We have to look at it three-dimensionally. And even if the face view was okay, the occlusal view was not okay, because you can clearly see that, yes, we have that buccal bulk, but the quantity of soft tissue in the coronal aspect would not be sufficient to create a tooth that is invisible. So we would have to make a flap, we would have to put an implant, and the tooth would look definitely longer than the neighboring tooth. So it takes one further step, and the further step is to work on the periodontal biotype. In this case, we harvested connective tissue from the tuberosity. The tuberosity connective tissue is a fibrotic tissue, so it's the best possible connective tissue that we can use when we want to get augmentation and we want to change the biotype. If you take a subepithelial connective tissue graft, sometimes we get a temporary benefit, but in the long run it returns as it was. But if we take the connective tissue from the palate where the gingiva is fibrotic, we get augmentation, and very stable augmentation. Well, we were lucky because you can see on the upper left side that the bone graft had worked, so ridge to ridge, the whole of the tooth was not there anymore. So we just increased the volume of the soft tissue. So we open and close the flap, repositioning everything as it was. And you can see in the lower right side that actually we were able to place back the tooth that we saved. We put it aside when we did the extraction. We put it back, and it was just working as a Maryland bridge. And now you see that we have that excess of gingiva that is fantastic because we can play around with that. There was no digital smile design, and there was no sophisticated implant navigation system because we're talking about 2003, 2004 when we did this procedure. So the implant navigation system was very, very Jurassic, I would say, very, very old and very, very primitive, but it worked because we were able to place the implant and to put the temporary crown at the same time. Later on, about 4 or 5 months after osseointegration was reached, we delivered a final restoration, cemented, with a Procera crown, and we published this case on the International Journal of Aesthetic Dentistry. So you can see that before and after there are no differences. Actually, probably the teeth look better after than before. And this young lady has a beautiful smile, and she maintained the beautiful smile. And what is more meaningful, this beautiful smile has been maintained throughout the year. So 2006 is when we finished the case, and 2018 was the last time we did the pictures and the radiographs to her. In 2018, you can see that the stability of this complex has remained unscattered because we did a careful planning, we did a very gentle procedure, and everything actually looked very nice, very beautiful, and very stable. Now, let's look at a very difficult case, because now we're talking about multiple extractions. We talk about aesthetic zone, so in this case, we need to have a combined approach. Here, the chief complaint of the patient is that she doesn't like, of course, the black triangles. So she's still a lady that is not young, but she's not old, and she still wants to look very good. So the request is to actually have 4 individual crowns and possibly have papillas. Well, this is a complex case because if we go and study carefully, you see the crestal levels are very low. There is increased mobility because the decay that cut away completely the lateral incisor induced an extreme stress on the other lateral incisor and the central incisor that are holding the bridge. So there is increased mobility, there is actually decay, and there is advanced bone loss. So we decided to study this case and plan it very, very carefully. This is the way she looks. You can see she is somebody that takes very good care of herself. So she is proud and she wants to look good. So the idea was to do ridge preservation technique. So extraction, very, very gentle. Then we grafted the socket, but you can see in the pontic area where she had the central incisor to the left side, we actually carved into the gingiva. We just cut with a round diamond burr into the gums, and we put a removable appliance so that the removable appliance could start shaping the soft tissue and giving an idea of papillas. Well, once the patient has healed, 5-6 months later, we are ready to plan our guided surgery. We plan for implants at a certain position because the distance, the inter-implant distance, and the position between the bone crest and the interproximal contact point, as I said before, is what is going to lead our regeneration of the soft tissue and of the hard tissue as well. So you see that before the surgery, the soft tissue have bounced back, but the waves are not fantastic. So we place the implants with the guided navigation system. We connect the temporary crowns, and you can see that 3 days it starts to look okay. So we start to have the gingiva actually coming back to us, bouncing back. Then of course we have to follow up the case because 3 months, 5 months, 6 months, 8 months, we have to change the interproximal shape, and there are areas where we have to remove some acrylic and areas when we have to add some acrylic, because at 5 months the papilla is going too much to the left, so we have to add some composite to the right side, of the left side of the central incisor to the upper right to push the papilla to the other side. Well, actually you can see that we reach a point where the patient is happy because she shows that she has now a nice smile. Well, she now has individual temporary crowns. So by having these individual temporary crowns, we are able to really condition individually the teeth. And you can see that the individual temporary crowns shape the shape of the soft tissue, the caul, as we really would love to have. Then we do the ceramic try-in, because it's time to go for the final restoration. In this case, Davide Bertazzo, our dental technician, does lithium disilicate ceramic crown, and Alessandro Conti, the prosthodontist, my office partner, does the adhesion on implants. So he, on T-base, is going to cement this lithium disilicate crown. So he does the etching, and then the rinsing, and then the actually rinsing of this lithium disilicate crown, and then the silane and the bonding, a thin layer, so that he can connect it to the T-base. He puts some Teflon tapes, and then puts the primer, and then the bonding, and then puts the crowns in place, and then does the cementation. Then the crown go back to Davide for the finishing and the polishing and the perfect cleansing. And this is the final result. You can see that we go from a very difficult situation to look at the interproximal areas and the black triangles that are very narrow, so you can expect the soft tissue to really become fantastic in a case like this. And 6 years after the procedure, everything looks beautiful, everything looks stable, and everything looks the way we were planning to have at the beginning. This is a close-up of the final restoration, and this is just a comparison between the initial situation and the final restoration as it looks now. That looks very beautiful. Now, I think we should start talking about a procedure that has really changed my life and really has given me a weapon that I did not have in the past. This weapon is the cortical lamina. The cortical lamina is a porcine collagenated bone graft that works exactly like a membrane, but is a membrane that is made of cortical bone. So it's fantastic because whenever I need to do a regeneration of a large area, horizontal or vertical, if I have the good anatomy, this is a fantastic help. Well, actually, the first one that spoke about the cortical lamina was Lars Ennerby. Lars Ennerby is the chairman of implantology in the University of Gothenburg, was a friend of Professor Brandmark. Actually, they were working on the same floor, 2 different doors, but on the same floor in the University of Gothenburg. And he has a group, a clinic here in Italy. He likes Venice in the northeast side of Italy. And basically, in a publication of 2010, he talked about the cortical lamina for the first time. The cortical lamina, basically, it's a semi-permeable, cortical, rigid bone membrane that, as you can see, has a lot of perforation. So even if it looks like just a piece of bone, there are areas where the bone can flow from the top to the bottom and basically give an exchange of vascularization. Remember that one of the keys to achieve bone regeneration is to have the cells, but the cells need the blood supply. So here, with this kind of membrane, we can have both the cells and the blood supply. So basically, the literature on the cortical lamina is growing. On the book that we published in 2014, Bone Biomaterials and Beyond, Hannes Wachtel and Tobias Stallmeyer had a chapter on it. Arnd Appe and Chris Lotte have another chapter talking about the lamina. And Michele Antonio Lopez also wrote about the lamina using the Curie technique. We are actually doing a nice lamina course that we run together. We are doing it next week, next Saturday in Rome. Is a 1.5 day course, and this 1.5 day course teaches you how to handle from simple to very complex three-dimensional defects with the cortical lamina. It's a course that involves hands-on, it involves live surgery, it involves all the aspects that are necessary for this procedure. Actually, for the Russian population, I will be doing this course in the Congress in St. Petersburg in the middle of September, the European Academy of Cosmetic Dentistry. So those interested can still apply. It's a half-day course with a slide presentation, but a lot of focus on the hands-on where you can get to use all the kind of lamina that you're going to see right now. So the lamina comes into 3 different versions. We have a curved lamina, that is the one that we use, we will see for the 3-dimensional augmentation. We have the flat lamina that works just like a resorbable membrane, but is made of bone. And we have the bone layer that is actually the substitute of the autogenous bone when you want to do the Curie technique. Let's look now. Very interesting, the multi-layer technique that was actually proposed by the group of Hannes Wachtel. They published 42 cases of implants in 5 years. That's the way they propose the use of the cortical lamina. It's when we do socket preservation or immediate implants. Basically, we extract the tooth, we shape, you see the lamina like a shield. We put the lamina between the residual bone and the flap, and then we put a connective tissue buccal to the lamina, and then a graft posterior to the lamina. So this is actually a multi-layer, because we have the graft, the bone graft, the lamina, the connective tissue, and then the patient's tissue. So a fantastic technique. So the curved lamina, it's indicated for both horizontal and vertical augmentation whenever the situation, the anatomical situation is favorable. So whenever you have the anatomy that is favorable, the curved lamina has a grip. It's rigid, and you can shape it, and it can actually bite on the bone, and you can actually stabilize it to the local anatomy, sometimes without even needing to use tacks or pins. One of the precautions you have to use that the cortical lamina should be dry until the end of your procedure. We will see now how it makes a big difference if you have a lamina that is dry and if you have a lamina that is soft. I mean, if it becomes soft, it loses its shape, so it tends to lose the volumetrical augmentation that you want to do. Well, the soft lamina, you can use it in many different situations. In this case, for instance, we had to extract a bicuspid and a second molar. You can see the defect is huge. So the defect was debrided. You see the small holes that are made in order to get the blood cell coming from the marrow spaces to participate to the healing process. We put the bone graft, we put the lamina, and then you can see that a few months later, the dentist that referred the case to me was able to place 3 Straumann implants and then to restore them. The bone layer is instead the lamina that we use in those situations where we want to do a graft Le Curie style. So if you want to do it like Fuad Curie would do. Let's look at a very nice case. This is a difficult case because you see we have a defect that is both buccal and lingual. We have a vertical and horizontal defect in this case. So we shape our Curie bone plate on the shape necessary. We just put it mesial and distal with 2 screws. We put one in the buccal aspect, one in the lingual aspect. Basically, we create a box. Inside this box, we put some autogenous bone mixed with genos, and you can see that 6 months after, we remove the tacks, and you can see there is a beautiful horizontal and vertical augmentation. It was placed 4mm implants here, and this is a fantastic result. This was a case that I borrowed from one of my best friends, Carlo Ghezzi, that is an active member of the Italian Academy of Aesthetic Dentists and also of the Italian Society of Periodontology. Well, talking again about the curved lamina, that is the one that we use in most of the cases, the cortical lamina basically has 2 aspects. It has an outer aspect that is cortical and an inner aspect that is cancellous. So you have to be careful because you should not use it upside down, or even if it's almost impossible to do, because otherwise you will not get the expected result. Actually, one of the best publication was done with a group of Professor Carlo Majorana in the University of Milan in 2016, because we did a study that was on humans and was a study that was also histological and histomorphometric. Basically, we did patients in the posterior resorb mandible where we did augmentation with the cortical lamina. Then when it was time to place the implants, we did 3 fines biopsies, and we sent them to Gothenburg, where the Professor Nanmark processed the histological section, showing that the lamina completely evolves and converts into vital bone. So the lamina gets basically resorbed and substituted by the bone that is underneath. So it goes under a process of mineralization, and when you open the flap, most of the times you don't recognize anymore the lamina as you place it when it was the time. But let's look at another publication that we did in 2017 that describes step by step the procedure of application of the cortical lamina. Basically, we had a case quite common, quite conventional for the resorb posterior mandible. you can see that the mandible twists completely to the lingual aspect. Therefore, if we were going to place the implants vertically, first of all, we have little clearance. Secondarily, we may interfere with the mylohyoid line. So basically, what the prosthodontist is asking me in this case is to completely reshape and regenerate the bone and give the bone an anatomy that is completely different. Now we have a bone that is dehiscent. We want to have a bone that is like shaped like a dome. And you can see that in my simulation, when I describe with the prosthodontics the technique that I want to use, what do you see in the pictures? I see the cortical lamina, because that is exactly the shape. It's also color white of the lamina that I'm going to use. Well, we take a stone cast of these patients. We measure the ridge in length, in width. We measure the interarch space, because we want to make sure that we have enough interarch space that if we gain space vertically, then we don't run into problem in placing the final restoration, and also to make sure that we have a possibility to have the teeth in the proper occlusion. Then we're very lucky because the University of Milan has a software that places the stone cast on a stand, and there are cameras that take a video 360 degrees around the stone cast and show us the amount of bone loss that we have. So we can really become terrified, because if you think that the prescription of the prosthodontist is to put 4.5 and 5 millimeter implants into this ridge, some can just run away and say, I'm scared, I don't want to do that. But this is very interesting. Then the surgical procedure is quite simple, because we open a full thickness flap. We expose the edentulous ridge. We try to split the keratinized gingiva 50% to the lingual, 50% to the buccal. And then we shape the cortical lamina and we sit it on the ridge, just like the saddle on the horse. Now, the problem is that you can see in the second picture, the big problem is that actually we now have like a pair of pants that is too small for our belly. So if we try to pull up the pants will not go because the belly is too big. So what do we do in this situation? Well, it's very simple. We do a soft brushing. With the periosteal elevator, we just brush the buccal flap. We hold it with the tweezers and we brush it and we pull it until we stretch it to a level that it will sit on top of the lamina. We do the same thing in the lingual aspect. So we do horizontal brushing so that the fibers that are in the lingual stretch, and we can raise the lingual flap up to 1 centimeter sometimes, but we don't want it too passive. We want to have a passive flap with a slight tension, because the two flaps, the buccal and lingual, should keep the lamina in place. Well, once we have assessed that the soft tissue will be in the proper position, we move into doing the marrow penetration. Meanwhile, we have placed the bone graft into a Dappen dish with the patient's blood clot. So the blood clot and the bone graft have already become one whole thing. If you want to use the PRF, IPRF, that's perfectly fine. You can do whatever you want, for as long as you get a bone graft. As you can see, that is very stable. And you can see that now, before even placing the lamina, we have a ridge that is now about 1 centimeter wide. So then we place the lamina, and then you can see how passively the flaps sit on top of the system, and we can close our sutures and everything is ready to heal. So we leave the situation for about 6 months. The longer we wait with the lamina, the better are the results. So we have to be very patient, because the lamina has to really convert into vital bone, so it takes some time for that. So the bigger the augmentation, the more we have to wait. The smaller the augmentation, the more we can re-enter quickly, but I would say never sooner than 5 or 6 months, possibly 8 months, sometimes 1 year, if you want to really find hard, vital, beautiful bone. So you can see to the right that the situation is completely different, and when we check with the new CBCT, we can really see that the shape of the ridge has become what we were aiming for at the beginning of the procedure. So now we can see that we are ready to place our implants, and when we open the flap, what do we see? Bone. You don't see the lamina anymore. You see the color, the texture, and when you drill through it, it drills like drilling through normal vital bone. So we place our 2 implants, then we cover them. Since they're transmucosal implants, we wanted to bury them, and we use the resorbable membrane just for the sake of getting a better healing period. And then you can see that about 3 months after, they're starting to appear. Now it's time for the second stage surgery, and it's also time to address the soft tissue, because you can see that we did not have enough keratinized gingiva. So you can see here that the way the anatomy before and the cast after the implants are already in place. The biggest satisfaction is when you see that you open your flap. Imagine that the second implant, the posterior one, is a 5 millimeter implant, and the anterior one is 4.5. You can see that there is bone buccal to it. So 5 millimeters plus 1 lingual plus 1.5 to 2 buccal. It tells you quite well how much of regeneration we got. We were very lucky because we had some keratinized gingiva on the ramus of the mandible, so we took it from there, not from the palate. We did a free gingival graft and we let it heal. Well, I think that the image of the stone cast before and the master cast after are quite self-explanatory of the amount of augmentation that we reached, and also you can see before and the time of delivery of the crowns. This was the case that I did with Dado Foce. Dado Foce is one of the finest prosthodontists in Italy. You can see before and after maturation of the soft tissue how the keratinized gingiva now well surrounds the crowns, and at 48 months after we removed the crowns once more to make sure that everything was okay, and everything really looked beautiful and nice and stable. So this is the stone cast with the healing abutment, of course, to show you how the situation has dramatically changed. Then we have actually another software that does the comparison before and after, but we will see it in another situation because the time is short. We still have 30 minutes, and I hope to give you more information about the lamina before we finish. So let's look now at the 2 different applications of the lamina. In this case, we have a severe defect. You can see that the ridge is completely a knife edge. So we want to augment this ridge and make it become a viable ridge for implant placement. So basically, you can see from the 3D and the CBCT that we have like a knife, and we want to make sure that we can put at least 4 millimeter implants in a kind of ridge like this. So we need really to change the shape. You have to see that the tip of the ridge needs to become like the pole that holds the system of the lamina that will change and reshape completely the ridge. So the placement of the graft, the placement of the lamina. The lamina, unlike most of the other membranes that we have used in the past, can be placed against the teeth because it's bone. So there is no contraindication. Actually, it's the best way to stabilize the lamina when you have adjacent teeth, just to really frame it, stick it in between the teeth so it cannot move, it cannot go anywhere. So you can see that after 8 months, things look very, very good. And when we re-enter the case, I was able to drill for 4.2 millimeter implants, and you see how much of the bone we have now, and you cannot detect the difference between the new bone formed with the lamina and the old bone that we had there. So the 2 implants, the healing, the flap is closed, and when we did the second stage surgery, you see that we start to reshape also the soft tissue. So we went from a very complex situation where even the vertical quantity of the bone was not there to a situation where we have 2 nice implants. And you can see this is the radiograph at the left is at the time of impression taking. I want you to notice the position of the head of these implants. What you would expect when you do a bone graft GBR is when you drill, you place your implants, then you load them. After 1 year, 2 years, you lose 1 or 2 millimeters of the crestal bone. Never with the lamina, or very rarely. So you can see this is already with the temporary crowns in place. And this is the way the temporary crowns have shaped the soft tissue. So we have now nice keratinized gingiva. And when we deliver the final restoration, everything looks nice. So these are the crowns done by Davide Bertazzo and Alessandro Conti. And this is 2014, 2018. Look at the crestal level. Nothing has moved. Everything is perfectly stable after 4 years. The more you wait, the better it gets. And with the time, the mineralization of the lamina carries on with the time and gets better and better. But now let's look at an almost impossible case, because here we need a three-dimensional ridge augmentation. We have a case that is nearly impossible because you can see in the CBCT that we have such a large defect that on the upper right side, the lateral incisor is held just by a slight piece of the periodontal ligament. The canine is just floating in the air, and the sinus has a wall that is so thin that looks like hollow. There is a hole. There is a communication. There is no communication. It's just that the bone is very, very thin. You can see in the crestal picture that the teeth are completely detached from the palatal bone crest, that is the only one left. So here the patients would like to have a new set of teeth. She would like to have fixed restoration. She has 3 areas of the mouth that we'll have to address with the cortical lamina, and it's a great challenge for us. So we decided to place the cortical lamina in the first quadrant, but of course, given the little quantity that we had, we needed to have some support. So the lamina can work, but if we don't have a proper anatomy, we need to use tenting screws. In this case, as you can see, I decided to put 2 tenting screws. The 2 tenting screws were 7 millimeter long, so they were actually protruding out of the bone crest by 5 millimeters, and the lamina was sitting on top of it. And the bone graft, of course, was underneath. But you can see on the left side that from the nothing, we start to see gray, and when we look at the CBCT before and the CBCT after, you can see that things are starting to look much better, and this gray triangle of bone is more than enough for an experienced implantologist to place some implants. And of course, in the end, we see that we were able to place 3 standard diameter implants, 3 megagen implants, and put some temporary crowns, and you can see how beautifully also the soft tissue react after the use of the cortical lamina, the fantastic transmucosal tunnel, and how very nicely everything looks. Now, this is the way the patient looks. We elected to use white acrylic instead of pink acrylic because simply it was fitting better in the pictures, I think, and I don't like to put flanges when I do fixed restoration, possibly only when I do large restoration, but for individual teeth like that, it looked better. And you can see that the final restoration is so much better. The only one that was not very happy was the husband of this young lady, because she gained weight again. She said when she had no teeth, she was not eating. Now that she has the teeth, she can eat again a lot, and then she gained a lot of weight. But that's actually life. So I want to show you a case of aesthetic dentistry that was handled by a combination of these techniques, the one that we have seen so far. This is a young lady that works for a dental business in Genova. She fell from the motorcycle. She hit the sidewalk with the face. She had a big trauma. She lost the central incisor, the soft tissue, and the hard tissue. So this is the way it's supposed to be. So you imagine how much of soft and hard tissue is missing in a case like this. And unfortunately, Nicole, she's a pretty lady and she works publicly, so she would like to have a nice restoration. Now let's look at the procedure. The procedure is very simple. In this case, we use the stent of the Invisalign just to be able to give her a temporary temporary tooth that was feasible. But you can see the distance between the soft tissue and the stent. So there is a big lack of soft and hard tissue. Well, we have to do a primary incision. We put always a releasing incision, if possible, to the most distal aspect of the area we are treating with our procedure of augmentation. We try to score to bone with the blade, and we try to split the papilla into parts. Then we help ourselves opening the flap with a tunneling knife, because we want to be very gentle in the aesthetic area. We don't want to compromise the papilla. So a very soft and gentle elevation of the flap. And then once we have assessed the situation, we can use the pre-treat. We collect the blood clot from the wound area, and we use this blood clot to hydrate the biomaterial or the bone graft that we scraped from a remote side of the mouth, and we put it together. Genos actually is the biomaterial that performs better under the lamina, because it's very hydrophilic, it's very spongy, so gives immediate stability. And as I showed the other night when we did the GTR seminar, basically it collects, it induces revascularization of the graft, because some morphogenetic proteins that are within the genos are actually responsible for, together with the cells that are coming from the bone marrow, to initiate the phenomenon of the growth factor that is called vascular endothelial growth factor, that produces regeneration and formation of the blood vessels within the graft itself. So here you can see that since we are in a small area and we need to coronally advance the flap, we can actually do the sharp incision, because we will not have much to do. We do sharp incision to coronally advance the flap. We perform the intramarrow penetrations with the round diamond burr. And then you will see how the graft that was hydrated with the patient's blood clot looks. Genos hydrated with blood clot looks like a sticky bone. Look at that. Really, you cannot waste any of the particles. You put it in place. Where you put it, it stays. So it's one of the most performing biomaterials that we have available on the market nowadays. At the end of the procedure, possibly we keep the lamina down with the periosteal elevator, and we suture the two papillas to the medial and the distal. So we keep the lamina pushed down against the bone and basically on top of the bone graft. So it's a very easy procedure. If you learn to do it, it really works very, very well. So about 8 months later, we reevaluate the situation. The situation looks very good, very healthy. So we take a new CBCT, and we are very impressed by the fact that in the new CBCT you can see that in red dots it's the original ridge, and in the white dots you can see the regeneration. But now we have to assess also the situation, so we do like a digital smile design, and we try to see if the teeth are going to look okay. We do the study with the R2 gate, the feasibility, the position of the implant, and the feasibility of a screwed-in restoration in case we get enough ISQ in a case like this. And of course, we try to match also the soft tissue with the hard tissue, and we go on performing a procedure with the R2 gate. So now you get to see also the way the R2 gate works in situation like this. We give anesthesia by using the wand device, so that we give the anesthesia from the palate, so that we can take pictures, we can take video, we can actually take photos, and the patient is cooperative. This is the R2 gate stent, and as you can see, It's a stent that sits on the adjacent teeth. In this case, we start with a guide drill. The guide drill is giving us the direction, the precise long axe of the implant that we're going to place. We move vertically up and down. We start with a short drill, in this case an 8mm drill, so that we make the initial hole a little bit deeper. And then we go with a 10mm and 11.5mm. So we go on by 1.5mm with increasing depth of the burrs. Once we have reached the desired depth with the drills, we start drilling sideways. So we start to widen the implant site preparation. And in this case, the 3.3mm burr is color gold. It's a 3-spade, so you have to use it very carefully with a movement of up and down, and you will see that a lot of bone is refined by the burr, so you find also a consistency of bone quite good in situation like this. So you use the lamina to improve the quantity of bone, but also the quality. This is the very minimal traumatism that we give to the patients by doing guided implant surgery in the aesthetic zone. Then we insert the AnyRidge implant that is quite aggressive, quite performing, and is the one that allows us to perform immediate loading if we get a good ISQ. So in this case, we need to adjust the crestal position. So when the green mark will appear in this window that we have in the stent, and we have on top the black line, means the position of the hexagon of the implant is exactly where we wanted it to be. We test the ISQ, and if the ISQ is, compatible with the ISQ that we have, basically we can move on and do the temporary restoration in place. In this case, this was the temporary after about 3-4 months. She was very happy. I am always very demanding, so I performed the Vista procedure. I put a connective tissue graft from the top down, and then after we have reached the perfect shape of the soft NR tissue, we performed crown on the implant, laminate on the central incisor, and laminate on the lateral incisor, so that she was so happy that January 12 she was going back to perform in the theater, and she took a series of selfies that were gratifying the office more than the money she paid for this procedure. Well, now in the left 15 minutes that we have, we can evaluate another option that we have when we want to do guided bone regeneration. So we can do vertical ridge augmentation of atrophic posterior mandible by using cancellous equine or porcine blocks. So basically this is a complex kind of procedure, because you have to cut with a piezo surgery, really like a drawer in the bone, cutting on top of the mandibular canal with 2 vertical incisions, but you have to leave the wedge that you see on top of the bone inserted with a hammer completely attached to the lingual flap. It's a quite demanding procedure, but you can see that you can create a slot that is 6, 7, 8 millimeters, where you can just shape your wedge of a block of bone and then insert it in this area. And then upon healing, of course, you can see that you get a lot of horizontal and vertical augmentation, and then place also quite long implants. This is actually taken from the work of my friend Pietro Felice in the University of Bologna. He's one of the #1 expert with this technique, that in my hands would not work just as well as his, because I'm quite shy in doing this kind of procedure in the posterior area of the mouth. Of course, nowadays the digital workflow helps us even to solve a critical situation, and here we see another complex case where we have advanced periodontal disease, so we have to have a strategy, and the strategy here is to have multiple extractions. In this case, we did not have yet the dentin grinder, so we had to extract all the teeth, put the bone graft, put a temporary full denture, and then wait for the healing, and then plan for a full arch case. So we extract all the natural teeth, we do the bone graft, we put a full denture on our patient, and upon healing, we can use, in this case, we use an OB clinician to plan the bone aspect to the left side, the soft tissue aspect to the right side. It's beautiful because by using this kind of implant navigation systems, we can actually foresee the position where the implants are going to emerge, the position of the emergence profile, the position of the lip. So it's a very interesting and modern way to approach complex cases like this. So you can see that after we have performed the ridge preservation, when we move on to do the full arch implantation, we have a lot of soft tissue and hard tissue. So we have not only the bone, but the soft tissue is in quantity. So we are very happy and lucky that we can perform implants in a mouth like this. So actually, if you look at the slices of the CBCT, you will appreciate very much that in white you see the areas where the bone graft was placed. So you imagine if we were not doing the ridge preservation technique in a case like this, we would never be able to place implant flapless. We would have to open a large flap from molar to molar. Would have been very traumatic. We would have to put the implant, put the graft, put the membrane, and then you have to put a full denture on the patient. So it's an incredible risk because every time you put a full denture on a patient, if you have the implant underneath, there is always something that goes wrong. So in this case, we were very lucky because we put the implant, the full denture on the grafts. So on the graft, nothing can happen. Simply, the graft will keep the full denture in place and vice versa. So basically, we plan for 6, all on 6, and you can see that we put our implants flawlessly, very easily. The patient did not feel any pain. At the end of the procedure, we had already the temporaries ready for him, and the ISQ was fantastic because we were 5 millimeter wide implants, and you can see also prosthetically how parallel, how well the disposition of the implant is amazing. So about 24 hours after the implants were placed, the patient throws the full denture in the lake, and he can walk out of the clinic with a full temporary sets of temporaries. Look at the beauty of this image in the radiographs, the checkup radiograph, and how nicely are designed these temporaries with the shape that will try to condition the soft tissue as much as possible. Well, in this case, again, we don't have to worry about aesthetics in terms of interface between the hard and the soft tissue because the lip line is very low. So we'll do it just for our pride to do a good job. So this is with the temporaries in place, the immediate loading, and you can see the X-ray, the perfect crestal level, the stability of the fixture at the crestal level after the graft is just incredible. So this was the day of surgery. Some months later, we take a plaster impression because we want to make sure that we have extreme stability. We do a zirconia framework designed in CAD-CAM by one of the best Italian lab, and actually we create a zirconia framework where we are going to cement lithium disilicate laminate. So it's quite a sophisticated kind of work. 6 lithium disilicate veneers cemented on the 6 upper anterior, so to give the patient a broad and young smile. This is the cementation phase, and this is the final manufacture. See, there is a lot of movement, there is a lot of shades and translucency that give a lot of customized smile. So it's something that does not look fake. It looks very realistic. So you see that by doing this, even if we knew that by extracting all the teeth in a patient periodontally compromised, we would have this big amount of bone loss, so we needed to compensate with some pink acrylic all of this, but actually at 3 years follow-up, you see that the crestal level are perfectly stable. The patient is in on the point in clinic, can maintain is working in a fantastic way, and 3 years follow-up, you can see that this was the final restoration. This is the follow-up. These are the soft tissue. We remove it when we do the recall visits. We like to remove this restoration to make sure that everything is stable. And if you have this kind of maintenance by the patient side, perimplantitis luckily is a very far problem. But of course, not all the patients have the motivation and they have the skill to keep and to maintain something like that. So you can see after 5 years, his smile is now very bright, he's very happy. He aged a little bit, but he's very, very, very happy. And we made a shape and a color of teeth that fits the age of the patient. So it's important to always try to give our patients something that is proper for the age group. Well, I want to show you one more technique that is quite efficient, although quite costly when we have to solve large defects, which is the box technique. The box technique is performed with a device that is called the sonic weld. The sonic weld is a sonic instrument that allow us to basically place some polylactic acid, polyglycolic acid pins into the bone and to weld onto these pins polylactic acid, polyglycolic acid membranes that allow us to become like the box that could be the cortical lamina in a case like this. See, the pin is going into the bone, heated by the sonic weld, and then with a twisting movement, we remove the instrument and the pin remains there. So we put 1, 2, 3 pins in this situation to create the buccal wall that is completely missing. This is the third pin. We go in, then you twist your hand, and that's it. 1, 2, 3 pins. Now, basically, we will attach the polylactic acid, polyglycolic acid membrane that has perforations, you can see. This is a long-lasting membrane. The time of resorption of this polylactic, polyglycolic membrane can be up to 12 months, sometimes even 18 months. But they give you incredible stability. So now I'm welding the medial part. And now basically I've created a big far wall defects. So it's very easy now for me to inject some bone graft. I have 7 millimeters of bone wall that was missing. And now I have a 1.5 centimeter with MP3. See, MP3 works in the sinuses, but this is like a sinus upside down. So I will just put my bone graft. I just compact it very, very well. And then I cover this whole system with a resorbable membrane so that this area will be left to heal, while the two posterior areas, luckily, I was able to place large diameter implants and with high stability, and we will put just temporary crowns on the two posterior implants. So this is the resorbable membrane that is placed on top of our system to cover up and to stabilize everything. And now we will do a split thickness flap in order to accommodate and bring the soft tissue up and to close the whole system before we are ready to actually place the temporary crowns. Okay, so this is very delicate. It's a very delicate procedure. And now you can see how much augmentation we achieved. We put the temporary abutment on the posterior. And 6 months later, you can see that the area is completely restored. So when we go back to re-enter, imagine this on top, you can see the defect. and in the bottom you can see a 5 mm implant that is lost in a desert of bone. So we have created a volume of bone that is just unbelievable. So we can see that we placed implants, and then eventually you can see that we took biopsies. We sent them to Gothenburg to Professor Nanmark that gave us the histological section showing that we have vital, beautiful, nice bone. So this is the final restoration before and after. This was the original defect. 10 years follow-up. Look at that. After 10 years, we have perfect, beautiful stability, both in the soft tissue and in the hard tissue side. Well, I want to finish my presentation showing you the worst case scenario. So how a case that is falling apart and a patient that is losing everything can bounce back by using guided bone regeneration. This is the situation. In the beginning, I could not even take good pictures because there was so much inflammation that the patient could not even bear the mouth retractor. So you can see that I extracted everything in one piece. I pulled the upper bridge and the lower bridge just by giving a little bit of anesthesia. Only the soft tissue were keeping this bridge in place. You can see that the defect, especially in the second quadrant, is majestic. So it goes from the lateral incisor all the way to the third molar. We put 2 temporary dentures in place. And then with a temporary denture already, we looked into some good aesthetics. We let the soft tissue heal. And then after we did the regeneration on the upper left side with the sonic weld and with the bone graft just as we have seen before, we planned. You can see how much of the regeneration we got. We can see really how bulky vertical and horizontal augmentation we got. And now let's watch the video of the procedure. So this is before we do the extractions. You can see that we are on the floor of the sinus. Basically, there is nothing left. The extractions, upper and lower, and this is what was left after we removed all that crap from there. So this is the membrane. In this case, we use 2 membranes with 4 pins. One in the buccal, one in the lingual. The membrane is 5 centimeters long and is 2.5 centimeters high. So we need a lot of membrane, and we need also a lot of bone because we are creating a box. It's a big box where we want to actually place our graft. So we're lucky that the MP3 is in a syringe, so we can inject it and push it up and push it quite hard as well. We compact it, and then we place a resorbable membrane, making sure that it covers up everything. We close quite carefully. And now you can see before and after how the situation has dramatically changed. In the CBCT, you can see in white the graft, so you can experience how much of the regeneration was done by vertical and horizontal augmentation. So this is in white, you can see the horizontal and vertical augmentation. These are the 6 implants as we planned it. And then we place the 6 implants with guided implant surgery. So at the end of it, we constructed a beautiful zirconia bridge on the upper and lower jaw. And we see the history of this case before, after the extractions, after the regeneration, with the implants in place, with the implants restored on the upper and lower arch, This is a follow-up of 6 years. And then I show you all the biopsies that were taken from the sites where we did the implants for in the regenerated area that show that we got live, beautiful bone. And then, of course, the most gratifying thing is the smile of the lady that now has no more infection. She's very healthy. She's very happy. And this is a CBCT that we took at 8 years. And in the CBCT, if you look on the upper right side, you can see how the crestal bone is fully recovered and fully reconstructed. So the GBR procedure worked very, very well. So stability is the key of the game. This is a follow-up of 10 years. The patient is very, very happy, and we are very happy that we got this beautiful result for her. Well, I think we got to the end of the presentation. I think I hope you had a good evening and a fruitful presentation. I want to conclude telling you that all the biomaterials work, even if in different ways. Some work in a biomimetic way, some really transform into bone. So it's a choice of the surgeon to pick the best biomaterial for your needs. And don't forget that our mission is basically the one to make the patient smile. This is what we do in my office in Genova. We organize group of dentists that come. We do live operation. We have a nice sala that is hosting up to 15 people that can watch and do the hands-on. And actually, this is a brief video showing you what do we have in Genova. We have many beautiful things, not only in the city, but in the surrounding. There's Portofino, Santa Margherita, a lot of locations that are good touristic spots. And if you wish to come and visit in Genova, we will be very happy to organize tours and to bring you out to see all of these beautiful places, especially this time of the year in the summertime. It's really, really nice. So I just want to remember that as a member of the board of the Italian Society of Aesthetic Dentistry, we will have in Rome our National Congress in October 25-26. You're all invited. We have super speakers. We will have Nizam Bicciaccio and Mirella Ferraro. We will have Roberto Pistilli, Simone Grandini, and Raffaele Sacerdoti. We will have Alessandro Pozzi and his dental technician, and the wonderful Agnini brothers giving a presentation on the veneer and the digital dentistry. Well, I hope you had a good time tonight. I send you a big greeting from Genova. Here you have my mail, my website, and you are welcome if you have questions to write me in the chat line that the company gave you, or if you want to have a personal conversation with me, to write me a mail, and I will be very happy to answer you. Thank you very much, and good evening to everybody.